Hi, everyone. I'm your host, Deborah Foreman, and I am the Educational Programs Coordinator for MS Focus. Before we start the webinar, I'd like to introduce this year's National MS Education and Awareness Month Booklet Toolkit. The theme for 2024, not four, is MS Warriors Battling Autoimmunity. We wrote this toolkit with the aim to provide a deeper awareness of the immune system, benefits of and advances in treatment, and how you can advocate for autoimmune research in your community. If you're currently subscribed to our MS Focus magazines, then please be on the lookout to receive your 2024 toolkit in the next few weeks. If not, please respond to your registration email of this webinar and we can add you to our mailing list. To make this toolkit and today's webinar possible, I would like to thank our wonderful sponsors, Genentech, Sandoz, Viatris, EMD Serono, and Sanofi. Thank you everyone for your time and enjoy the webinar. Now I'm thrilled to introduce our speaker. Daniel Kantor, MD, is board certified neurologist and the president emeritus of the Florida Society of Neurology, founding president of the Medical Partnership for MS, past chair of the Florida Agency for Healthcare Administration's Pharmacy and Therapeutics Committee, past director of Florida Atlantic University's Division of Neurology, inaugural neurology residency program director at the Florida Atlantic University, past director of University of Florida's Comprehensive Medical Multiple Sclerosis Center in Jacksonville, Florida, the neurology representative for First Coast Service Options, Contractor Advisory Committee, and an adjunct full professor in Nova Southeastern University's Institute for Neuroimmune Medicine. He is a board certified in both neurology and headache medicine. He is the chair of the subcommittee on concussion of the Sports Medicine Advisory Committee of Florida High School Athletic Association and the vice president for clinical research and development at the Neurological Research Institute, focusing on finding a cure for Parkinson's disease. After Dr. Thrower, Dr. Kantor is proud to be the second longest member of MS Focus's Healthcare Advisory Panel. Dr. Kantor, we're so pleased to have you join us today, and thank you for taking the time out of your busy schedule to educate us all. So I'm going to turn it over to you and go for it.
Well, thank you so much for the introduction. Today, what we're going to talk about is your medication working for you? And I'm glad to be kicking off the National MS Education and Awareness Month. Remember, it's not just a week of awareness, it's a full month of awareness. And so I'm so happy that MS Focus, the MS Foundation, is really focusing so much on how we can educate everybody about multiple sclerosis. So another way of thinking about this is MSTAR, and we'll go through what MSTAR is, but it's the multiple sclerosis team approach rule, and it places you at the center of that team. In the 1400s, there was a person who fell and she got weak, and then she got better. She lost vision in one eye, then she got better. Because bad things happened to her, followed by good things, the Catholic Church decided that she was a saint, and they named her Saint Ludwina, patron saint of ice skating. Now we think of her as the first person in recorded Western history to have had multiple sclerosis. What can we learn from that, and what can we learn from everything that we see in multiple sclerosis? Well, in 1903, Sir William Osler said that the best teaching is that taught by the patient himself. It was 1903, so we'll forgive the late chauvinism. He didn't say herself or themself, but that's still true today. While your doctors can read textbooks and they can read papers and they can go to conferences, the most they're going to learn is actually from interactions with people just like you. When I moved to Florida 18 years ago, we started something called the Multiple Sclerosis Team Approach Rule. And it's a very simple idea. It just places the person with MS at the center of that team. On the one side, you have the primary care physician, physical and occupational therapy, speech therapy, MS nurse, case manager, neurologist, nurse practitioner, physician assistant. And on the other side, you have the friends and community, the significant other, and family, which I think are a lot more important than those doctors that I listed before. We also have the job, and in America, we're lucky with the American with Disabilities Act that we can retain our jobs if we need to, and then when it's time to apply for disability, that's also available if someone needs to do that. And then there's the MS community. The MS community is made up of nonprofits, large and small. It's made up of national nonprofits. It's made up of regional nonprofits. It's made up of other groups. It's made up of all the people who are listening here today. And the important part of all this is that it's not the significant other, it's not the neurologist, it's not the researcher. The person with MS is the center of that MS team. But what is MS? I want to make sure that we're all using the same language. And I actually recommend that when you're talking to your neurologist, to make sure that you're all on the same page. You might think it's obvious what you think of MS and what they think of MS, but I think it's worthwhile, at least at the beginning when you meet them, to make sure that you have the same outlook and you're looking at the same goals. Because remember, these goals aren't just lofty goals for science. These goals are how we make you better and how we keep you better. So MS is a lifetime autoimmune diagnosis. I use the word lifetime, not chronic, because chronic makes life sound long and arduous, and lifetime is like the cable station similar to that name. When you turn off the TV, this cable is still going on in the background. And even when you're not watching TV, you still have to pay your cable bills. Well, the same is true with MS. Even when it's not rearing its head, people have to take care to not get into an MS relapse or into MS progression. And the best way we know to do that, as we'll see, are disease modifying therapies. It affects the central nervous system, not the peripheral nervous system or other parts of the body. And that's mostly the spinal cord first. And most people don't realize that. They think about the brain more often because that's what your neurologists are going to order. MRIs of the brain are more common. The picture is much clearer. The brain is much bigger than the spinal cord, which is pretty thin to see. And all our clinical trials look at brain MRIs and not at spinal cord MRIs. After that, the optic nerve is involved, as well as the brainstem as the third most likely. We think of it as problems separated in time and space. What we mean by that, it's not a Star Trek reference. What we mean by that is that a person will have different neurological problems at different times, so not the same thing over and over, and it will affect different parts of their central nervous system. So that's the difference in time. So it's not just a one-time event. It will happen more than once, and space because it will be different parts of the central nervous system. We think of it as both demyelination and axonal loss. For a long time, we talked too much, I think, about myelin, and now we're again remembering what we learned over 100 years ago, which is how important the axons or the wires of the nerve are important. And in fact, we actually think that sometimes that we can use the myelin as scaffolding to help the axons grow. Because if you lose the myelin, it's hard for those axons to grow. So you need really both of them to work together. Another thing that works together is both your genetics as well as your environmental trigger. What I mean by that is that a twin with multiple sclerosis, their identical twin doesn't have a 100% chance of having MS. They have only about a 30% chance of having multiple sclerosis. And so we know that genes are important, and we've discovered many genes that are associated, not that cause MS, but they're associated with MS. But genes are not everything. And Michael J. Fox, America's sweetheart, when he was describing Parkinson's disease, which he has, he said that in Parkinson, genetic loads the gun and environment pulls the trigger. He could have been describing multiple sclerosis. So what do we think happens? These activated T cells, this is how we've traditionally thought that these immune cells would cross the blood-brain barrier. They would launch an attack on both the myelin, the covering of the nerve, and the nerve fibers, and it would obstruct the nerve signal and make it that you're less likely to conduct electricity in the way that you should. That sounds simple enough. And then we started telling people that they should look at this figure and try to memorize it. But in all reality, what we've learned and what we tell our residents now and our fellows and our other neurologists that we're teaching about multiple sclerosis is that this information is actually outdated. We now know that it's not just the T cells, but we know the importance of the B cells. And really, in the 2010s, that's what we've learned. We've learned that we move from just the T cell to the B cell, but not just the B cell, which is a type of immune cell. It creates antibodies, but the way the B cell and the T cells interact and their regulation becomes important as well. What else have we learned? So what have we learned in the last decade? What we've learned are some updates in MS epidemiology. Epidemiology is a study of diseases in populations. So we've learned more about where MS happens, where it doesn't happen. We have updated phrases or nomenclature. We talk about activity and we talk about progression. We can say someone has multiple sclerosis with activity, without progression, or with progression, without activity, or with both, or without both. And so we just have a different terminology that we use than when you may have been diagnosed. We published a presentation and a paper several years ago that actually looked at this. I did this together with a patient, a person with multiple sclerosis, and we talked about how when you look at it, doctors and patients are sometimes using different languages. And it's so important for your doctor to never, ever, ever use jargon. Jargon is a fancy word that means fancy words. Now, one of these fancy words is NIDA 3. NIDA 3 is, the question is this idea of no evidence of disease activity, which is our goal nowadays, not just to reduce problems, but to have no evidence of disease activity. And we had one that had 3 components, and that was more about activity. And then the 4th added also your brain tissue loss. So how much our brains are shrinking. Because everybody, whether you have MS or not, over time, your body shrinks and your brain shrinks. But somebody who does not have multiple sclerosis, it shrinks a little bit. Somebody with Alzheimer's, it shrinks a lot. And for multiple sclerosis, we want to take it and we want to make that person shrink less and be more towards what a normal, healthy brain would look like. We also have these questions about progression and progression independent of relapse activity. This is a hot topic nowadays. My question is this really such a novel concept? We've known for a long time that there's big inflammatory changes that we call relapses that you can see with MRI, but then there's other inflammatory changes that you can't see on MRI. And you may say you're having a problem, and your doctor will say, well, the MRI was normal, or the MRI didn't show any changes. That is not an answer. All that means is it wasn't large enough for it to be seen on MRI. Also, besides multiple sclerosis, we've started focusing on multiple sclerosis plus or MS plus. And these are diagnoses that can be diagnosed with labs plus phenotypes. When we say phenotypes, what we mean is a description of what kind of problems you have. So we think about something called neuromyelitis optica spectrum disorder or DeVick's disease. And even more recently, there's something called myelin oligodendrocyte glycoprotein antibody associated disease. And we're finding that some people that were classified in the past as MS maybe had MOGAD. And certainly in the past, people with NMO were in the original clinical trials for many of our older MS medications. Now it's time for you to learn how your neurologist actually thinks. I think it's important in your office visit to really get an understanding of each other. The neurologist is trying to understand you, but you should have some clues into how the neurologist is thinking. So this might be a secret, so my colleagues might be upset with me, but the way we basically think is localization, and that means what part of the body is affected. Is it the central nervous system, the peripheral nervous system? Is it the autonomic nervous system, that flight or fright idea? Is it not neurologic? And then we think about etiology. Etiology is asking you what caused it. What is the cause of the problem? And so you can imagine all the questions that your doctor asks you in history. They ask you lots of questions that you've been asked before, and they ask you over and over. But each of them has ability to help us either with localization or with etiology or with both. So your age doesn't tell us anything about where it is, but it can tell you what's the cause. If someone's much older, you might think, well, if they're having neurological problems, our first thing we should think is stroke. And if they're very young, we should think that it's a newborn type of illness. If someone's in their 20s to 40s, oftentimes MS is one of the most common diagnoses. Handedness, we ask people whether you're right-handed or left-handed. That actually helps us with localization. What I mean by that is when we do the Simon Says of physical exams, we say lift up your arms, no, don't do that, twist like this. If we see that someone's a little bit slower on one side, but that's their dominant side, so they're right-handed and their right looks a little bit slower, that's very different than if they're left-handed and their right looks a little bit slower, which we would expect. So a person's sex can help us in terms of etiology. Some things are more common in men than women. 2/3 of people with MS are women, but that still means that a third of people with multiple sclerosis are men. We're learning that race, although we can think of it a lot of times as a social construction, we can teach us a lot about etiology because some things are more common in some races or than others. And in the past, people mistakenly thought that people who were African American or blacks in America would actually not have multiple sclerosis. What we found out is that's not true at all. And in fact, they found in Southern California that there were more people with who were African American had MS than people who were Caucasian who had MS. And Hispanic Americans were somewhere in between. The symptoms we ask about you that can help us with localization. The timing, when did it start? When did it stop? What happened? That can help us with what caused it, not with where it is. We ask you what makes things better, what makes things worse. That can help us both with localization as well as etiology. If we ask about the prior workup, what tests did you have before, that can help us both with localization as well as etiology. Asking about your family isn't going to tell us where the problem is for you, but it may tell us that there's something that's going along in families more or less likely. But we have to remember that MS remains a diagnosis of exclusion, which means your doctor is going to take your history. 85% of what we do as neurologists is taking your histories, asking you how you're feeling, how you're doing. And we have to make sure as physicians that we pause for enough time to hear your answer. We don't stand next to the door and tap our watches to let you know that we're not that interested. We want to know what's going on with you, and the history can be very, very important part of MS in general. Your physical examination, and obviously as neurologists, we focus on your neurologic examination. It's a very lengthy examination that helps us sort out where things come from. There may be tests that we do, for example, labs. So we might want to rule out other labs to make sure you don't have something else going on. We may do MRIs and other kinds of imaging, and that would help us tell us if it's MS or something else more or less likely. And then there's other kinds of specialized testing, things like evoked potentials, visual evoked potentials, so other kinds of electrical testing that can help us in the diagnosis of MS. So what are some of the history questions? Well, your doctor, and this isn't just, if your doctor doesn't ask you this, you may want to phrase it in this way. You may want to think in terms of this way, because this is really how your doctor is thinking about it. Well, they want to know when the symptoms started. They want to know, does anything bring it on or make it go away? Anything make it better or worse? Is it affected by heat? That is very important in multiple sclerosis. MS is not the only neurological condition which gets worse in heat, but it is very classic in multiple sclerosis that a person who is exposed to heat, which doesn't only mean outside heat, it could mean the humidity, it could also mean your internal heat because you have a fever or vigorous exercise, and that can make a person's nerves not work as well. And when you have MS, your threshold is just not as good as it was when you didn't have MS. And so what that means is that you'll have short circuiting, which will be at even lower temperatures. Because all of us, you could raise the heat enough that everybody would have a heat stroke. We want to know, is there a band-like sensation around the trunk? That helps us with understanding, is this partial transverse myelitis? Is the spinal cord involved in multiple sclerosis? Does it feel like an electrical shock with your neck flexion? So you push down your neck, you flex it downwards, and you have an electrical sign. We actually call that Lhermitte's phenomenon. And that was described originally not for MS, but for people with very large discs. So they had their disc was herniated in their back, in their neck, and it was pushing on the spinal cord. Nowadays, we have other tests like CAT scans and MRIs, so people don't usually get to the point where they have such a big disc protrusion. So if someone has electrical activity with neck flexion, a lot of times we do think about multiple sclerosis. We want to know, is there a similar problem in the family? Is there a family history of autoimmune disorders? When we say, is there a similar issue in the family, we actually don't mean that people with MS are going to necessarily have other people with MS in their family. More likely, they're going to have other people with autoimmune disorders, and they themselves may have other autoimmune diagnoses as well. To give you an idea of your MRI, and I show this because I think it's important for you to ask your neurologist. If you are interested, then you should be able to see your own MRIs. When you go and get your MRI, wait the few minutes for the technician to burn that CD so that you have a copy. Keep one copy for yourself and give one copy to your doctor, because you cannot be sure that the physician or the physician practice or all the other people that are there are going to actually return that MRI to you. And you may need it in the future. Because remember, medical records don't last forever. Nowadays, when they're computerized, it's easier to think they last forever, but they don't have to. They don't legally have to. And many MRI facilities every 70 years are going to actually purge the information, and you may not have your old MRIs. What we see here is a person where they had an original scan, and the lesion that we're pointing at is that white matter lesion, or a plaque, we also call it. And then at another time, so after 2 months, that lesion has gotten a little bit better. We can see with the white arrow, but then in the yellow arrow, we have a new lesion that came. And so we have some fixing going on and some more problems of both demyelination as well as remyelination. I said that the nomenclature or the language has changed. Well, we talk about different types of MS. Relapsing is most of what we focused on in our past. Progression, progressive MS, is becoming more important to address, because as we develop more than 20 different medications, different names of medications that we have for relapsing forms of MS, we still only have one for primary progressive multiple sclerosis. And so several years ago, the committees came together and we decided that there was something called clinically isolated syndrome, and it's not distinct to MS. Usually what happens is a person will have one event, and that's the first event that will eventually become MS. That person may be active or may not be active. And then a person will most likely, after either 5, 10, or longer years, turn into relapsing remitting multiple sclerosis. And then we can think about somebody who's having activity, so having MRI changes and having relapses, or someone who's not having activity. And then in terms of progression, we can talk about a progression where you have active disease going on. So you still have inflammatory reactions, but you also have progression independent. So things are getting worse even independent of those relapses. And that's why traditionally we've talked about this idea of RRMS, SPMS, and PPMS. So this idea of relapsing remitting MS, secondary progressive, and primary progressive MS. These images are very important because they basically are still true today. What happens in relapsing remitting MS is that a person is okay, things get worse, and then they get better. It happens over 24 hours, usually over weeks to months even, but they might not always get exactly to where they were beforehand. And so there may be an accumulation of disability that happens, that stepwise approach. In secondary progressive MS, people start out the same way, but then they either continue to have relapses, and in between the relapses, they get worse, or they don't have any more relapses, but they slowly get worse. Somebody with primary progressive MS should start out from the beginning having progressive MS. What we've learned in the past 5, 10 years is that a lot of people with primary progressive MS actually have relapses also. It's just that their story didn't start out with relapsing, but they may also have relapses which can respond to therapy. Oftentimes, your neurologist is interested in this time. They're interested in that short period where things are getting much worse, and it's something that can be seen by your primary care, seen by your neurologist. You may end up as a stroke code in the emergency department because people don't know why you're weak. That becomes, for medicine, that becomes a really important time. I would argue that for people with MS, that's not really the most important time. The most important time is that vast amount of time in between where a person has day-to-day symptoms. And interestingly, you'll see that we still, in neurology, we talk about relapses of MS and trying to reduce those, but we don't talk about the day-to-day symptoms as showing us that a person has activity. From my point of view, however, you could stop all the relapses you want, and the person could not be progressing, but if they have day-to-day symptoms, they don't feel like their MS is under great control. We talk about different kinds of symptoms. As you can imagine, there are some symptoms that are more common than others. And we've seen in these two studies, well, when you look at it, actually sensory changes are the most common first and ever symptom of multiple sclerosis. And actually, those come not from the brain usually, they actually come from the spinal cord. Progression in MS, we think of it as relapsing remitting MS. You could accumulate disability from your relapse. You could have secondary progressive MS that is active, so you could still be having relapses, or you could have and MRI changes, or you could have non-active secondary progressive MS. And then there's also primary progressive MS, with can be with relapses or without relapses. What are the problems that happen from progressive multiple sclerosis? Well, the symptoms can cost because the actual symptomatic therapy, so that can cost society, can cost the person themselves. Absenteeism or presenteeism. Absenteeism means you're not there. Presenteeism means you're there, but you're not quite there. And so you may go to work, but you're just not at your full potential. You may go to school, you may have family functions, but you're not at your full potential. The care partner, the person who lives with that person with progressive MS, they may lose productivity because of taking and helping to take care and working with somebody with multiple sclerosis. From a disability point of view, disability is bad in general, but if you think about it from a cost point of view to society, work accommodations can be an issue. Someone might no longer be working and they may be applying for disability. From a mental health point of view, this can really cause a strain on a relationship. And there are, unfortunately, people who have gotten divorced. Now, divorce is just very, very common in society, especially American society. But sometimes people having a lifetime diagnosis can either bring two people together or it can really separate them. And I think that's a true test of both a relationship as well as a character. When there was a hurricane that was hurtling towards Orlando, when we were down in South Florida, what happened is people were cutting each other off, honking, being mean to each other. My patients in Orlando, one person came and helped the other person and put their stuff in their attic so that it wouldn't get washed out by the water. You saw people helping people. And I think that's a true test. And I think for a lot of people, you don't choose to have MS, but I think what MS has shown is how strong people can be. And then we have to think about mental health like depression. Depression is common just in general. And of course, having a progressive diagnosis can lead to that as well. Now, we think of MS as a clinical diagnosis. The history, we're going to look carefully at the past. The exam is normal, old, and or new findings in different parts. So someone might have normal exam, but they actually have multiple sclerosis because in their history they have it. The labs, we oftentimes rule out other causes, but there are new biomarkers emerging. MRI, we look at the brain, the optic nerve, and then less commonly the cervical and thoracic cord. Sometimes people will have a lumbar puncture or a spinal tap, and there we'll see an elevation of IgG index or oligoclonal bands, or actually neither of those. And that's the issue with spinal taps, is that if it's normal, it doesn't mean you don't have MS. And if it's abnormal, there are other things that can mimic multiple sclerosis as well. And then there's these electrical tests that many people don't use, but evoke potentials. We use visual evoke potentials more than brainstem and somatosensory. There's a great MS Foundation or MS Focus support group in DeLand, Florida called the MS Musketeers. And they let me use their name. I don't know if Disney let them use it, but I use it to describe the three MS Musketeers. So what are the three swords of treatment? Disease modifying agents, symptomatic treatment, and acute exacerbation treatment. I actually am also a migraine doctor, and we talk about the same things. We actually use different language, but we talk about this idea of prevention MS disease modification. We talk about abortive treatment, like what happens when you have an attack, and that might be symptomatic treatment. And then if you're in a cycle where you just can't stop with the symptoms you're having, or you're having a relapse, or for example, somebody with headache is having chronic daily headache, then we want to rescue them. And that's when we use things like acute exacerbation treatment. Most of the focus has been on disease modifying therapies for MS. And the reason for this is that we've come so far. In 1992, we had 0 disease modifying therapies. In 93, we saw our first one. And now in 2024, I need 2 slides just to show you the different names of the medications. So what you see here are the generic names of the medications. Some of those medications are now available generically. Some even have biosimilar. One of them is, we also have pediatric dosing. And so as you can imagine, there's lots of different kinds of medicines, and you want to know a couple things. You want to know what you're on. You want to know what are the potential benefits and risks, but you also want to know why your doctor put you on that one and not on something else. This really has to be shared decision making of coming together and making a decision together. Our job as neurologists is not to live life for you. It's not to tell you what to do, but it's to guide you from our experience, from what we've seen in terms of other people. Another way of thinking about this is the intersecting spheres of treatment. You can think about self-injectables. You can think about intravenous medications or IV, as well as oral pills as well. And this slide grows and grows every year as we develop more and more medications, which is quite amazing. And as you can see from this slide, we started out with medicines every once in a while, and then now we've reached a point where we're having so many medicines that are being developed or being studied or coming out. So these are proactive medications. What do we mean by that? We mean that we're not using it to treat a symptom. Many times somebody with MS will say, well, I don't feel better. Well, that's our goal, but it's not really what the medications are supposed to do. The disease modifying therapies are supposed to prevent you from having more attacks and maybe prevent you from having disability as well as MRI changes. So the goal of MS is to do this, and we can think about these medications as disease modifying therapies, disease modifying agents, or disease modifying drugs. And their aim is to prevent both relapses as well, to a certain extent, progression of physical disability. No diet alone has been proven to do this. There are some diets that people may have heard of, like the Wallace diet, that people focus on. What these diets haven't done, they've helped people symptomatically, but what they haven't done is change the course of multiple sclerosis. And no supplement or vitamin has been proven to do this either. We were close a couple of years ago to biotin being that first vitamin that was actually having real studies that was able to show it, and unfortunately, those trials were negative. How do these medications work? Well, you'll hear this a lot. We don't truly understand how MS disease modifying therapies work, but we say that about almost every medication for almost every condition. We don't always fully understand it. But we can broadly classify them as being immunomodulators, changing the way your immune system works. Then we can think about it in terms of keeping your immune system away from the central nervous system. So keeping your immune cells in your periphery, in your bloodstream, and not going through into the central nervous system. Immunosuppressants, just pushing all the immune cells down everywhere. We can think about resetting the immune system. And we think about that in a way, that's how we think actually stem cells may work. Stem cells aren't replacing cells. People used to think that about stem cells. But stem cells, what they can do is they create an environment that can make a person almost reset themselves. And we see that with one of our medications that's used. It's hardly used in the United States and even globally, but alemtuzumab, we actually think of resetting the immune system. And now we have another medication, cladribine, that we think does it to a certain extent as well. So how do they work? How do these medications work in progressive MS? Well, we don't fully understand how they work. But the possible mechanisms are remyelination, so using that myelin scaffolding that can also be used to fix the axons, axonal repair, so actual repair of axons, energy metabolism, fixing the way the energy is working in your cells, or even neuroprotection, stopping you from having problems in the first place. What do we know about efficacy? Well, we know about efficacy is that in the past we compared things to nothing, to placebo. Now it's very difficult to do a large clinical trial without comparing it to another medication. So placebo or sugar pill or the idea of no active treatment. And then more recently, you've had interferon beta 1A intramuscular, also called Avonex. Interferon beta 1A subcutaneous or Rebif has been a comparator. And the most recent trials have been against oral teriflunomide, also called Aubagio. The FDA has made it clearer, and I'm very happy the FDA has done this. They used to talk about MS differently. Now they talk about relapsing forms of MS, and they say to include clinically isolated syndrome, relapsing remitting MS, and active secondary progressive MS. That's very important because I found that neurologists sometimes would say, well, no, they need to have relapsing remitting disease. They can't have secondary progressive. That's not true. If someone has active secondary progressive MS, meaning having relapses, having MRI changes, that is what these medications are FDA approved for. And then we also have primary progressive MS, where we have that one medication called Ocrevus or ocrelizumab approved for. There's an older medicine hardly used in the United States for a long time called myoxandrone, and its label is just a little bit different, but that's because it's an older medication that has some limitations in terms of heart problems as well as in causing blood-borne cancers. So as you can imagine, that's not a medication that we choose in the United States. So how do we know if the disease-modifying therapy is working? Well, we can use the clinical trial endpoints. We can think about what our neurologist says. What does your neurologist look for? And then we can think about what's important to and for you. Not what's important for someone else, what's important for you. So how does clinical trials work? Well, in clinical trials, the way we measure MS is we think about phase 1 trials are going to be often people who do not have the diagnosis. So oftentimes people who we call normal or healthy. Sometimes you'll have people with the same diagnosis, especially if the medication is potentially very toxic. Then what you might do is you won't test it on people who don't have the disease because that doesn't make any sense. If you have a terrible cancer and this medication is very, very harsh, you may test it only in people with that terrible cancer. You're going to test for the safety of the new medication. That's going to be our main goal in phase 1 trials. But we're also going to look for how the best way to give it. What's the timing? What's the dosing? What route of administration? How are we going to give this medication? Phase 2 trials. Phase 2 trials are in people with the diagnosis in question. So phase 2 trials are going to be in people with multiple sclerosis. Efficacy is what we look for. We look for how well does it work in terms of getting to these endpoints. And I call these faster endpoints because as you'll see, these endpoints aren't what we use for phase 3 trials. In MS, we usually use the number of contrast enhancing lesions. It's a little misnomer. It's actually called gadolinium enhancement, not contrast, but we mean the same thing. The idea of that heavy metal dye that they give to you that can brighten things and show active lesions in MS. And we're looking at it in these trials for brain MRIs, non-spinal cord MRIs. And in MS, these are usually 6 months long and several hundred people. In the phase 3 trials, we're talking about more like 1,000 people. And we have longer and a bigger trials. We usually have a clinical endpoint and we look for patterns of side effects. So we want to know, we heard something about safety in phase 2, but now we want to know, like, what do we really understand? Who can we predict that in? In MS, usually our primary endpoint is something called annualized relapse rate. I don't love it, but it is our most commonly used endpoint. The reason I don't love it is because the annualized relapse rate doesn't mean to you as a person how many relapses or how many attacks or exacerbations you're going to have. It says in a whole population how many attacks were they divided by the number of people. So, for example, if you have a 1-year study and you have 100 people with 1 attack each, your annualized relapse rate is 100 attacks divided by 100 people divided by 1 year. So the answer is 1. If you have a 1-year trial where 50 people have 2 attacks and 50 people are very different, they have 0 attacks, that's still 100 attacks, still divided by 100 people, still divided by 1 year, and that has the exact same annualized relapse rate with very different populations. In MS, we usually use our secondary endpoints, We use the brain MRI. We want to know about the white spots. We want to know also, is there enhancement of them? So are there T2 hyperintensities and is there gadolinium enhancement? And oftentimes, what we'll use also in a secondary endpoint is disability progression. Many studies haven't shown it to work in there in terms of disability. And part of the reason may be that not that many people accumulate disability in MS clinical trials. They're only 2 years long, or sometimes they're even 1 year long. So it's very hard to see that. We choose which people we put into a clinical trial versus not. And so oftentimes there'll be no difference between the drug and what it's compared to in terms of disability, but that's just because people in both groups did really well. In MS, we usually have these phase 3 trials as 2 years, sometimes 1 year long. Phase 4 trials, which you may not have heard about, are also called post-marketing trials. So the drug or the medication is already FDA approved, and now we're testing it in the real world. So we want to know is how well does it do in a population that's not that strict population. In a clinical trial, we ask you exclusion criteria. Yeah, you can't have too many of other diagnoses. You have to be a certain age. It's not how things are in the real world. And phase 4 trials can help us understand other populations better. And we may also look in terms of safety monitoring. Like, what do we do over time? Because if you have a very rare side effect, you're not going to see it in a phase 1, phase 2, or phase 3 trial. And you may need to have continuous monitoring going on in terms of a phase 4 trial, where what you have is you have this post-approval safety monitoring going on as well. But how does your neurologist determine how well your medication is working? Well, it's not exactly the same. They think about the number and the severity of relapses, exacerbations. The first thing is in the clinical trials, there may be mention of severity, but it's not actually a strong or high endpoint that we have. The neurological examination, which is also not an actual endpoint in clinical trials. We use something called the EDSS, or the Expanded Disability Status Scale, which is a formalized, all the time the same neurological examination, but it's not the same as what your doctor can tell from seeing how your reflexes are going, for example. Your doctors, fortunately or unfortunately, are going to be focused on MRIs, and they focus much more on the brain than the spinal cord. And that makes sense to me, but if you're having a problem that's coming from the spinal cord and you do an MRI of the brain, of course you're not going to see a problem. That's like saying, well, I broke my arm, but my doctor did an x-ray of my foot and they said everything was normal. Well, of course everything was normal. You looked at the wrong part of the anatomy, the wrong part of the human body. The doctor may think about whether there's disability worsening. And emerging, coming out now, are these blood biomarkers. I put this name here just because you may have heard about it, serum neurofilament light chain. And so the idea is that we may have biomarkers that can help us in the future. I do not think we're there yet, but can help us in the future in terms of knowing if someone's getting worse or not. The reason I don't think we're there yet is because you don't have to have MS to have problems with serum neurofilament light. You have that in people with heart disease, people with other kinds of conditions. So if somebody with MS looks great and their MRI looks great, but there's a problem in their biomarker, that might not tell me that we're catching it early. That might tell me we're capturing some other diagnosis that's happening to the person. Most importantly, how do you know if your medication is working? Well, you ask yourself, is it harder to do things than in the past? And I actually use that as a way for people to understand the difference between progression and symptoms, or progression and relapses. If you say, I'm not walking today like I did 5 years ago, that's slower. That's probably progression. If you say, I'm not walking today the way I did 2 weeks ago, you're describing something that's new. You're describing what we call an exacerbation or a relapse. So does that mean that you do activities slower? Are you slower at things, still able to do them? Or are you not being able to do everything that you were able to do in the past? Are your day-to-day symptoms worse? I mentioned before, and you saw neither in the doctors or the clinical trials do they focus on symptoms, but I believe patients really do. Are your symptoms, your day-to-day symptoms, worse or not? People will think about the number and sometimes the severity of the relapses, but oftentimes the relapse, it's something that happens and then you're better, and then you may not think about it all the time. Your time missed away from work, from school, from family. The time you're there, but not really there, the time where you have that presenteeism, that's going to tell you how you're doing as well. People do focus on MRIs. I find that people like the idea of a picture. They think it's more objective. And so people, not just the doctors, patients also focus on MRIs as well. And then there will be these blood biomarkers in the future that patients may say, well, my blood biomarker is getting worse, so I feel that means I'm getting worse. What are the future of these clinical trials? Well, there's a lot of medications being studied. Most excitingly, we thought the next medications were something called Bruton tyrosine kinase inhibitors, and there's many of them, and this is just some of them. Recently, we had the results from the phase 3 trial of the first one, evobrutinib, and it was not better than teriflunomide or Aubagio. And so evobrutinib will probably not be developed further. What's interesting to me is that it didn't say it was not better than nothing, than placebo. It just said it was no better than what we already have. And we're reaching that point where we have so many medications that if a medication is just similar to what we have, we probably won't use it as much or use it at all if the FDA doesn't approve it. We talked about this idea of disease modifying agents. We can think about symptomatic treatment, and we can talk about acute exacerbation. So here to show you some MRIs, what you see here, the white area that you're going to see, not the white in the middle, but the white spots are going to be the actual gadolinium enhancing lesions that are the bigger lesions that you see. It means there's more inflammation, a bigger relapse. You can certainly have relapses where you don't see any changes. The MRI hasn't changed. And it might have to do with your timing of the gadolinium. It also may have to do with people forgetting the spinal cord. And the person may have a gadolinium enhancing lesion in their spinal cord, but not in their brain. And so their doctor says, well, you're not having a relapse. So what are relapses or exacerbations? And this is very important for you to talk to your neurologist to make sure you have the same use of language. These are new or worsening neurological symptoms consistent with MS. They are subjectively reported or the doctor actually sees them. Individual or combined symptoms last for at least 24 hours. Things that get better and worse during 24 hours, we don't think of that as long enough to call an MS relapse. A little bit of that is just terminology, but a little bit of that is that the inflammation might be different if something's day to day versus if something's lasting for 24 hours or longer. We want the onset to be separated by 30 days or less, or 30 days or more from the onset of the previous attack. So basically, if you have an attack, you don't say, well, I had 50 attacks this month. No, you can only have one attack in 30 days. If you're having newer symptoms, it may still be we call it part of that same attack. We also want to make sure you don't have something called a pseudo relapse. Pseudo relapse, the word pseudo means it's not really what it is. It doesn't mean you're faking. It means that if you increase someone's heat, they're going to have symptoms that look like a relapse, look like an attack. We want to make sure that a person doesn't have a urinary tract infection or a lung infection, that there wasn't some other reason for a fever, there wasn't the hot water baths or showers, environmental heating, and stress can also increase your body temperature. When you go to Dr. Google, almost anything you look up could be an example of an MS relapse. There are some that are more common and easier for both you to know as well as your doctor to know. So how do you know if your relapse treatment is working? Well, it gets you back to where you were before, or it helps you to improve, maybe not completely, but it helps you improve your functioning and also stop your worsening. And that's going to tell you that relapse treatment is working. Because we think over time, even if you don't take a relapse treatment, that you will get back to where you were at the beginning, or you will get back to where you were meant to be. And that may be an accumulation of disability. But most people don't want to live 2 years with more disability. They'd rather do it faster. And that's why they think about medications like steroids, etc., that can actually make it happen faster and can make you get better faster. And then the final 3 musketeers is actually going to have to do with symptomatic treatment. Remember, we talked about the different types of MS. We talked about the day-to-day symptoms. You've seen this image before. MS symptoms can be very varied. And in different parts of the world, we can see different things happening. But we should not forget about the spinal cord. Most common symptom ever and initial is going to have to do with the spinal cord. And so we think about the cervical spinal cord, the thoracic spinal cord. And as you can see here, the person clearly has both cervical and thoracic lesions, but their brain isn't that impressive. And so, in terms of the lesions, and so we really can't forget about what's going on in the spinal cord. When you talk to your doctor, I think there's things to fix sometimes. I like to classify things as visible symptoms, invisible, or private. What I mean by that is if you're not walking right, someone from across the road would see that and say that's a visible symptom. If somebody is having fatigue, that's an invisible symptom. If someone's having a bowel or bladder or sexual dysfunction, that's not invisible because it's not invisible to their bed partner, but that's more of a private symptom. And I think it's important to think about these symptoms also to help you in terms of prioritizing which one you want to treat first. Because we can't treat everything at once because then we won't know what's helping and what's not. And these symptoms, much like the relapses, could be almost anything you look up in Dr. Google. We talk about medications, but there are other approaches. There's multimodal approaches. Communication, education, and the Multiple Sclerosis Foundation is a great source for that. Physical modalities and the Multiple Sclerosis Foundation is a great source of that. You need some sort of device to help you get around. The Multiple Sclerosis Foundation may have a program for you. Occupational and other therapies, pharmacological interventions. Yes, you go to your plumber for plumbing, you go to your surgeon for surgery, and you go to your medical doctor or neurologist, you're going to get medicines. And we also want to understand factors. Is it heat that's doing it? What's making those symptoms happen? So how do you know when your symptomatic treatments are working? Well, your symptoms, not everybody else, not theoretically, your symptoms improve or even go away completely. That tells you that your treatment's working. The patient voice, the person with MS voice is so important. We think about education, and that's why I'm so happy to be talking during MS Education and Awareness Month. We can think about support groups, both in person and then increasingly over the last several years with the pandemic, they've been online, as well as not-for-profits. These not-for-profits can be large, like the MS Focus or MS Foundation and the MSAA, both of which are national organizations located in one place. MSF is located in Fort Lauderdale, Florida. MSAA is located in New Jersey, but they give services to people all throughout the country. The National MS Society is the one you think of with different chapters, used to be statewide, but now regionally. And they're much more focused on collecting money and raising money to be able to advance research in multiple sclerosis, not for the practical day-to-day. Then the MS Coalition brings all these nonprofits and others together. And MS Insight is one example of a patient nonprofit that we use to help educate people about multiple sclerosis. So what do I tell people? Get prepared for the visit. Make a list of questions and concerns. Bring a typed list of your allergies and medication. Bring your actual MRI CDs with you, not just the report. I want to actually see the MRI. Tell the office your specialty and retail pharmacy names and information how to reach them. Know your authorization anniversary date. If you've been approved for a medication, chances are in a year, the doctor will have to go through all the same prior authorization. There may be different questions. And if you go and see someone and you don't realize that you're going to need it, and you see them and then 2 months later, they have an authorization, it's not going to happen at the right time. The person might not realize it might go to the bottom of the doctor's list in terms of their faxes. And so it's very important to know your authorization anniversary, make those appointments like 1 month or 2 months beforehand, but not 6 months beforehand. Have your pharmacy send in a refill request. It's not enough just for you to say you need a medication. If your pharmacy has a way electronically or paper of sending us a request, and we can easily send it back to them. You want to also, before you travel far, you want to make sure the office has your labs and other diagnostic tests before you show up to the office, and a lot of time has to be spent looking for them, or even a delay, or maybe not make you not even able to see the doctor that day. When we talked about the multiple sclerosis team approach rule with a patient or person with MS in the center, we can take different people with MS and they can work together. So you can have different MSTARs, so different ones of these that work together in terms of both patient care, education, and research. And when we think about the greater community of people with multiple sclerosis, different MSTARs can help each other. We see people helping each other. helping each other in terms of education, helping in terms of each other in terms of knowing where to go to. If you don't know which physical therapist, talk to your support group, talk to other people near you. They may know in your local area. No one knows your local area as well as people who are actually living there. And that's why our goal is to actually form the multiple sclerosis patient network with this idea that people with MS help other people. The great news is that there's more research in MS than ever before. And so in the 1950s, we had a couple of maybe one or two papers. Then we started to see 75% of our journals are actually involved and talk about research in multiple sclerosis. And this is just rising asymptotically. Even with us having already over 20 different medications, we're still seeing a lot of research. And I hope that together we can make the multiple sclerosis team approach rule turn into the multiple sclerosis team approach reality. I'd like to thank you for your attention, and I'd be happy to take any questions.
Wow, that was awesome. Thank you. Thank you. Thank you. So let's see here. We might as well tell everybody how, for those that have not joined us before, let me explain that now that we're going to be doing a Q&A, if you have a question, you can ask it by using the Q&A button in the app, or ask it live by raising your hand using the raise hand button. Or if you're on a phone, you can just hit *9. So let's see what we have. That was such an incredible presentation. Let's see. We have two questions that came in. Rita would like to know what meds are approved for secondary progressive.
Okay, so Rita, your question was what medications are approved for secondary progressive MS? Remember that when we talk about secondary progressive MS, we could be talking about secondary progressive MS with activity or without activity. So that means, and we saw those two images of secondary progressive MS where a person still has exacerbations and MRI changes, or people who don't have them, but just have accumulation of disability. We call that inactive secondary progressive MS. There is no medication that on its label says that it's FDA approved. We treat people, but there's no medication that says it's FDA approved for inactive secondary progressive MS. If you have active secondary progressive MS, then all the medicines that are approved for relapsing MS, they're approved for you. The FDA makes it very clear that that includes secondary progressive MS with activity.
Thank you. Rita's asking, any meds that help with PIRA, smoldering lesions? Two questions.
So earlier I talked about this idea that we could have these progression independent of relapses. So do you accumulate progression, accumulate disability even in between attacks, nothing to do with the attacks? Now, more recently, some people have started calling this smoldering MS. What they're describing is not something new. What they're saying is just like we knew before, there are going to be big lesions and big attacks, big inflammation, and then there's going to be smaller ones that you don't necessarily see on MRI, and they're going on in the background, and we call that smoldering multiple sclerosis. All that it means by smoldering and multiple sclerosis is that you're catching things that aren't the large lesions that are happening. We were hoping that our first BTKI inhibitor, or BTK inhibitor, Bruton tyrosine kinase inhibitor, evobrutinib, was going to be able to show that. Unfortunately, that trial, at least the results that we've seen, has been a negative results, that it had basically the same efficacy or strength as Aubagio or teriflunomide, but a little bit more different types of side effects.
Joseph's asking, which DMTs are not dampening the immune system?
It's a great question. So the question was, which DMTs, disease-modifying therapies, are not dampening the immune system? Because we've talked about how your immune system is involved, but your immune system is really important for other things. Fighting off day-to-day infections. You may be a school teacher and you're exposed to things all the time. You may be living through a global pandemic like all of us did. And so you want to think about that. Some of the medications are going to actually push down your immune system. Most of our medicines, especially the earlier ones, don't actually push down. They don't make it harder to fight off infection. What they do actually is immunomodulate. So we take it from what we call a T helper 1 way of attacking. So those T cells, a certain type of T cell attack in the body, and we made it more T helper 2, which was not the cause of multiple sclerosis. And so We wanted to kind of push it towards a more reparative or a less problematic part of the immune system.
Okay,
So
thank
the
you.
interferons, so the older medications, interferons, glutathione, we think of them as immunomodulators. In terms of our newer medications, well, some of the medications they don't push down your white blood cells, but they stop them from getting into the brain and spinal cord. And so we need the immune system in our brain and spinal cord to a certain extent. And that's why some of you may have heard of something called PML, or progressive multifocal leukoencephalopathy, where people with multiple sclerosis on certain medications have actually developed infections that can even happen in the brain. And that's why our medicines are very serious. It's a very serious question. And you got to spend your time with your doctor. If your doctor is not spending the time with you, go to a different doctor.
Good point. Someone's asking, is there a percentage for liver damage with teriflunomide?
Yes, the question was about liver damage with teriflunomide. Teriflunomide or Aubagio, it's a pill once a day with or without food. It has as one of its potential side effects, every medication is either goes through the kidney or the liver. It goes through the liver. And actually, we can see that there can be people who have more liver problems. But when you looked at the kind of lower amounts, so just like people who have kind of a little bit elevation of liver, you saw more with Aubagio than being on nothing. But when you start looking at like 7 times greater amounts, so your liver is really a problem, there actually was no real difference in terms of that. And so there can be people with mild to moderate. There are some people who have severe liver problems. What we do because of that is we monitor a person's labs. We monitor, especially the first 6 months. And then afterwards, it's a question of how we all do it. But we might want to check their liver tests every month for the first 6 months. In Europe, actually, they check every 2 weeks.
And what are your thoughts on the importance of exercise and stretching?
Exercise and stretching is very, very important. We now know that exercise is not just good for your physical body, it's also good for you cognitively. So there was a great study looking at treadmill exercise, and people who spent time on a treadmill, it's not just that their body got better, they actually had better cognition or better thinking. And I don't think it's something special about that one type of exercise. I think running outside probably has the same benefits. It was just that study was controlled. You kept people's temperature the same, and you had them go. You didn't just have them run outside. You had them on a treadmill. So we know that exercise and stretching can be really important, especially if you're developing spasticity or muscle tightness. And also, it can help you not just feel better, it can also make you feel better in terms of how you're thinking. It can reduce potentially depression. It can reduce for some people other forms of anxiety. It can make some people think better. And so I think diet, uh, as well as exercise and stretching, are really important aspects of multiple sclerosis.
Thank you. If somebody else, for Shonda, is asking a question, it's interesting, this question to me, because just yesterday I got my first phone call that came into the foundation asking the same question, wanting information about tumefactive MS. So she was diagnosed with tumefactive MS, and she can't find any information on it. Do you have anything you can share?
Yeah, so tumefactive MS, for most people listening, this is not something that they're going to need to know day to day, certainly. It is something you should talk to your neurologist about. If your neurologist doesn't know about tumefactive MS, that means they're not knowledgeable enough about MS. Tumefactive MS, tumefactive means it acts like a tumor. It's not a tumor. It's still MS, but the lesions are these big lesions. So they're much bigger and they look differently. They look more suspicious like a tumor rather than the MS regular lesions, which are going to be small and ovoid, kind of an oval shape. And so somebody with tumefactive MS, the question is, do you treat them with just the same medications? Personally, I think of it as aggressive multiple sclerosis. And so if I'm deciding with the person, deciding between two medications and one has higher efficacy or more aggressive than the other, I'm probably going to choose that more aggressive medication.
Thank you. And Nohora is asking, what is the reason that MRIs of the spinal cord are not used in clinical trials?
Great question. So when I moved down from Philadelphia down to North Florida, where I directed the MS Center, One of the first things I did was do MRIs on all the people with MS, and I did their spinal cord MRIs, even if they didn't have symptoms. And we found a huge proportion of those people actually had lesions. And not only T2 hyperintensity, also gadolinium enhancing lesions. Your insurance is going to make it harder to get MRIs of the spinal cord. It's very hard to do the brain and the cervical and the thoracic all at once because of time. It's also very hard to do it because you have to put people inside different kinds of cages, we call them, in terms of making the signals better in the MRI with cervical or thoracic. And we give the dye, and so you give the dye after you do all the brain and all the cervical and all thoracic, and then you have to move people all the way around. And then if a person doesn't show up, then the MRI facility just lost an hour and a half of their time that they could have been seeing three other people, for example. But you think about it from an anatomy point of view, the brain is going to be the picture, it's going to be that big. When you look at the spinal cord, it's very, very narrow. So there's a very small circumference. And so what that means is that the picture, there's going to be more noise to signal. So we call something signal to noise ratio. How much do you actually see of something versus how much is just electrical activity and magnetic activity that's happening. And it's much fuzzier in the spinal cord than it is in the brain.
Do you think, would you consider Zeposia an effective medication? And when, if ever, would you move to a more aggressive med such as Ocrevus?
So the question was about two medications. One is called Zeposia. Zeposia is also called ozanimod, and it is the penultimate. So there's one more approved after that, but the penultimate sphingosine 1-phosphate receptor modulator. That's a mouthful. But in 2010, our first medication for MS came out that was oral. It was fingolimod or Gilenya. In that medication, you have to do a 6-hour monitoring. You have to do EKGs beforehand, vital signs every hour. Now with these newer medications, we build up slowly, so we titrate you up. The medicine themselves may have less of an effect on the heart potentially, and there may be less slowing of the heartbeats. And so what will happen also is that for most people, are Zeposia is a possibility for them. There are few people who have heart problems that can't be on it. Most people can, and most people don't even need to have an EKG beforehand. In terms of also, looking at the back of the eye, we look for something called macular edema or swelling of the macula part of the eye. We see that less in Zeposia or ozanimod than we see it in the other sphingosine 1-phosphate receptors. So the way I think about it is I think about the original medications, the interferons and glatiramer. I think about them as being kind of here in terms of strength. Then I think in terms of strength of the newer oral medicines that are now generic, by the way, teriflunomide, Aubagio, and dimethyl fumarate and all the fumarates. I think of them actually having very similar to the interferons and Copaxone. Now it's a pill versus an injection, so that's also a difference. But there's studies I don't think really showed that they were much different. And then I think about the medicines that are like the sphingosine 1-phosphate receptor modulators. Medicines, like I said, Gilenya, fingolimod, and medicine that's used a lot nowadays called Zeposia or ozanimod. And then you have some medicines that are even higher in terms of efficacy. While they haven't been compared head to head, probably ocrelizumab or Ocrevus, which pushes down your B cells, which during the pandemic was an issue for people because they had to think about whether they wanted to do that. And so it's more effective than that, and it's only twice a year. And then there's a medication that's hardly used in America and most of the world. It's actually the most effective, and that's called alemtuzumab or Lemtrada.
Matt would like to know what the difference is between Ocrevus and Briumvi.
Absolutely. It's a great question. The question was about the differences between Ocrevus or ocrelizumab and Briumvi or ublituximab. So a year ago, more than a year ago now, there was FDA approval of a IV medication that also pushes down B cells. So it does the same thing basically that ocrelizumab does. The problem is we don't know which one's better or worse. We know that you can do it faster than you can do ocrelizumab. On the other hand, in the clinical trial, there were more people with side effects from the infusion on it, maybe because you're going faster also. Maybe that's just the reason why. But then in real life, it doesn't look like it's that much of an issue. Maybe the first dose for some people, but not nearly as much an issue as we saw in the clinical trial. And you can infuse it faster. So you can infuse it over 1 hour instead of 2.5 or 3 hours. And so I don't think we'll ever see a trial that compares them head to head in terms of efficacy, because you would need tens of thousands of people to see a difference. If there is a difference, it's a very small difference. But there is one thing that we know is different. When we talk about ocrelizumab, what we think about that is that it's a humanized antibody, a monoclonal antibody. When we think about rituximab, which is not FDA approved for MS but used sometimes, that's chimeric, means mixing human and mouse parts together to actually make the medicine. But ublituximab is actually also glyco-engineered.
Hmm.
And what that means is they realize that there's two parts of a monoclonal antibody. A monoclonal antibody means mono, one, clonal means they're all the same. An antibody is one thing that sticks to another. And so it can push down the B cells. So we talk a lot about what this connects to. It looks kind of like a V. But then there's this longer part here. And we don't usually talk about it, but that's important too, because that's connected to the cell that's going to eat or destroy what we're trying to destroy. And if your connection isn't so good, well, you might connect well here, but if you don't connect well here, then you're not going to have as much effect. And it does look like in all the other medications like ofatumumab, which is another anti-B cell, rituximab, ocrelizumab, what you have is you have 40% potentially of people who have a change in their DNA. The fancy word is polymorphism. And what that means is that they don't connect as well to that long part of the antibody. What they did with ublituximab or Briumvi is they actually glyco-engineered it. So they did like engineering on sugars, and they changed something called the fucose, not fructose, but fucose, and they made it that it should bind much better for all people, not just for some people in the population.
Thank
We
you.
don't know if that we don't know what that means clinically, how much that means it has an effect or not. Because once again, like I said, I don't think we'll ever see these medicines head to head compared.
Dr. Kantor, I know we went over with your presentation. Do you mind staying a few more minutes just to
That's fine.
knock out some of these questions? Okay. Carol has a very interesting question. Do you think people can be born with MS and it just shows up later in life, or is that really not possible?
You know, interestingly, we just had a large meeting for MS called the American Committee for Treatment and Research in MS, and they asked the pediatric MS doctors there what the youngest patient with MS they had. Usually, we think about people in their 20s to 40s when it starts. 10% of people with MS start out before the age of 18. The youngest I've personally diagnosed was 7 years old, and the youngest probably anybody is diagnosed is 3 years old. There's been no one who we think that from the beginning. Because if it's a problem of your white matter and your nerves, they need to first form. You're still myelinating actually into your 20s. That's why we probably don't see it as much. So you're still in formation. So how can you have attack of something if it's not even made yet? And certainly for a baby when they're first born, they're very incompletely myelinated. And that also means that there's less myelin for the body to get angry at and for the immune system to attack. We do think more about other things that can be dysmyelinating, or we think about things that can be familiar or genetic that can be a problem with the fact that you never formed myelin right in the first place. Not that it was formed right and then had a problem.
Hmm. How long on average should one allow a new DMT to work before thinking about
Great
going?
question. The question is how long on average should you allow medication to work? It used to be we said longer and longer, and then we said, well, there's difference in some medicines. Now, basically, if you look at every trial, the separation happened at 3 months. It didn't happen before 3 months. Part of that is because the first time they came for follow up was at 3 months, so it's hard to see it beforehand. So I would say you give it 6 months to start seeing something. If you're not seeing something after 6 months, there's a lot of other choices. If you've gone through everything, you don't have that many other choices, so you may wait a little longer. You don't want to go through everything too quickly because then you won't have anything to be treated with. And there was a study of a medication called Avonex for interferon beta 1A. I don't think it was special to Avonex, but it was very special in that it showed us that people who didn't respond in the first 6 months, those were the people that were the hardest to treat.
And what would
And so,
I'm
yes,
sorry. What would your opinion be on older people with MS stopping their DMTs with stable MRIs?
the question was about older people. The question also becomes what is older as we all age. For all of us, that definition of older becomes problematic. And I know one of the frustrating things in the community is that there's so much focus on people in their 20s, 30s, 40s, and then you may not even allow people over 55 or 16 to your clinical trial. But there are people who are in their 90s who are having active MS. There was a study called DISCOMS or DISCO MS, and it was about discontinuation of MS. The headlines by the authors were not correct. They were not what they found in the study. They published a study, and in the study, what they found is that people who were completely stable, no activity, no relapses, no MRI changes, and they took those people off, and there were more people who had MRI changes afterwards.
Oh,
There were even some people who had relapses, so it was even worsening clinically to a greater extent to MRI. Yet somehow these authors concluded that that means that we should stop medications. I actually would argue that we've all seen patients who we say, you know what, you've been so long, you're getting older, let's stop it. And then such a terrible attack happens. I think until we get better at predicting in terms of biomarkers, in terms of, say, these lab biomarkers, and who's going to get worse or not, I think it's very, very difficult. So I think it depends on what medication you're on, what that means for you. Are you paying out of pocket? There's lots of things to think about. What other medical conditions you have, how does it fit into your lifestyle? But a person coming off, even someone who's stable, coming off a disease modifying therapy has the risk of something bad happening afterwards.
I'm glad you talked about it because we get really every time we have a webinar, we get questions about that. So,
Yeah, I'll tell you, it's interesting. A colleague of mine, Dr. Hunter, and I, we wrote a letter to the editor after they published that paper, and interestingly, they wouldn't publish it. But our maybe we were too strong in our wording, but really don't think it's right. And these authors are friends of ours and colleagues, but we don't think it's right how they designed the study, which is a whole other issue. But they designed the study and then the results came out and then they misconstrued what those results meant.
okay. Catherine, we're going to take her as our last question. She's asking, what would you monitor on a patient on Ocrevus and at what intervals?
Excellent question, and a question close to my heart, dear to my heart, is that one of the problems in medicine in general and neurology is that there's no consistency. So you go to one doctor, they say one thing, one doctor, they say another thing. When I became a father, my daughter's now almost 9 years old, I realized it's so terrible for patients. We went there and the pediatrician, one pediatrician would say something, the other pediatrician in the same practice would say the opposite. And then the third would say something else. And it became very confusing. And so one of the things with the Medical Partnership for MS Plus, MP4MS Plus, which started in 2010 and now is over 1,300 neurologists, meaning that's 10% of all neurologists in the United States and a quarter of all prescribers of MS medications. And we talk without pharmaceutical companies listening, without government listening, where it's just the people who are actually taking care of people with multiple sclerosis. And one of the projects we did was look at what the FDA recommendations are versus what the real recommendations are versus what's the minimum if someone didn't have great access to labs. Because the FDA does tell you a little bit about monitoring, but it doesn't tell you enough. Even with the interferons, the way we would monitor, it wasn't what was written in the label. We would monitor more than it says. So for ocrelizumab, a little bit depends on the person's history of infection, but I would say that I would probably, measure their CBC and differential. I personally like getting a T and B cell lymphocyte panel uh, that tells me about their B cells and how many B cells they have. You could do P cell profiling, but that's not actually available in clinical care that much. There is a lab, but it's hard to do. I'll do chemistry. I think most people, whether they have MS or not, thyroid should be checked probably once a year. Vitamin D should be checked once a year. Vitamin B12 should be checked once a year. And if you have a mutation on your methylation, like MTHFR mutation, well, your vitamin B12 might look completely normal, but you have high homocysteine, meaning that your vitamin B12 is not working the way it's supposed to work. And B12 is very important for how most of the body works, but also how neurons or nerves work. And so people with Ocrevus, I would say what I've noticed is that they're having labs usually every 3 to 6 months. I say 6 months because you're going in every 6 months to get treatment. So you know you're capturing a person around that time. And some of those people are doing so well that they're just not going to the doctor for that third month visit. And so they may not have their labs being checked. But I would say certainly every 6 months to be doing those labs that we talked about, the CBC differential, the chemistry. We want to make sure that someone doesn't have something else going on. And we may want to do serum immunoglobulins, telling you how much of the antibodies you have, not because of MS, because of how much you're at risk for an infection or not. Remember, some of these medicines, ocrelizumab included, can affect your ability to have certain types of infections. And we follow their immunoglobulins because if your immunoglobulin is too low, it means you don't have enough antibodies to fight off infections. And so that might make us extra cautious. We may think even about treatments. We may think about going to a different treatment.
Thank you. And that brings us to the end of this event. If you've missed any part, it has been recorded and will be available through the MS Focus and YouTube channels, or rather the MS Focus Facebook and YouTube channels. Please reply to your registration email for any more information regarding what we're going to be doing in the future. By participating in a short survey sent to you after this webinar, you'll help us to learn the type of information and the meaningful and helpful ways that you'd like us to help you. As the attendees of this conference, that really helps us. So since we can't call you and ask you, we need you to fill out the application, or rather the survey. If you'd like to support programs like these, consider donating at msfocus.org/donate. Be sure to check out our supporter savings program where you can save more than you give. Join us next time on Tuesday, March 12th at 4:30 p.m. Eastern with Dr. Ben Thrower. He's going to be discussing research updates on MS and autoimmunity. Thank you, Dr. Kantor, our attendees, and our wonderful sponsors, Genentech, Sandoz, Beatrice, EMD Serono, Sanofi. And have a great night, everybody. Thank you so much, Dr. Kantor.